You're breaking up.
I'm muted.
I said you were breaking up. You said you will start with introductions, you introduce the topic, and the moderator. That was the last I
Oh, yeah.
heard.
And the moderator. Then you give us housekeeping. Everyone should keep their questions till the end. They can also put our mics muted. And then we will begin the questions. And after questions, we'll then take comments from our teachers and trainers who are online. So thank you, everyone, and welcome to the presentation.
For my children's day.
Oh, good. No, don't touch, don't touch.
Okay.
Introduce us or to welcome us to the 18th Residents Webinar Series powered by the Nigerian Society of Anesthetists. I will now be calling on our moderator for the day, who would moderate the session, introduce our speaker, and give us our housekeeping rules. So our moderator for the day is Dr. Ishola Esther Omolola, a registrar in the Department of Anesthesia. ahead. Hello. Okay, I think I'm audible now. Yeah.
Yes, you are. Are you speaking? Because I can't hear you anymore.
Okay. Moderate.
Okay, good evening, NSA, Nigerian Society of Anesthetists. Our teachers and trainers are present, and every other residents available for this webinar today. I'll be introducing our presenter, who is Dr. Rufus Glory. She's a registrar at the Federal Medical Center, Asaba, Delta State, and she'll be taking us on central venous catheterization. I, however, want to give us quick house rules. Please mute all devices while the presentation is on and keep all questions till the end of the presentation, where you can indicate by raising your hand to ask questions, or you can drop your questions in the chat box while the presentation is ongoing. Without more ado, I would call on our presenter to commence the presentation. Dr. Rufus Glory, please.
Okay. Good evening to our teachers and trainers. Thank you, Dr. Ishola, for the introduction. I'm grateful. Good evening to our fellow colleagues and other residents present. Thank you for your presence. So I'm Dr. Rufus Glory from Federal Medical Center, Asaba, a registrar. So I'll be presenting central venous catheterization and cannulation. And my presentation will be guided by this outline: an introduction, gross large zone anatomy of relevant vessels, indications and contraindications, patient selection and consent, monitoring, technique and approach, complications that could arise from the procedure, preventions, conclusions, and then I will give my references. So by introduction, central line catheterization is a common procedure performed usually in the intensive care unit, though it can be performed intraoperatively in the theaters too. It's a medical procedure that involves the insertion of a catheter into a large vein, typically in the neck, the chest, or the groin region. These catheters allows for direct access to the central venous system for various medical reasons and for treatment. Central catheters are of two types based on the locations of their insertion site. So we have the peripherally inserted central catheters, also known as PICCs, which could be inserted into one of the veins in the upper arm. It could be basilic or a cephalic vein, depending on the choice of the anesthetist. PICCs are regarded as a longer version of middle line catheters, which are long enough to be advanced into the superior vena cava and are used as alternative to central venous catheterization, as they are less problematic. An average length of a PIC catheter is about 40 to 55 centimeters and could have about 3 to 4 infusion channels. This is a pictorial representation of a typical central line kit setup. So in this kit, we have several things to enable us to successfully place the central line. So in the kit, we have a central line with three infusion pumps or 3 infusion channels. We could also have the one with 2 lumens, depending on our choice or what is available in our centers. Then we have the guide wire, which is also essential. We have the lidocaine and the infiltration as an infiltration agent with a syringe, which is also regarded as a trocar, which will enable us to locate the vessel of choice. We have the scalpel, we have the tissue dilator, we have a suture materials as part of what we need, and we also have a dressing material. And we also have a sterile ultrasound probe with a gel. And because most of these procedures currently is being advised that we should use the ultrasound head in order to reduce the rate of complications that could arise from this procedure. So this is a typical example of a central venous catheter. So what we have is a 3-lumen central venous catheter with different ports for different reasons. So the white port or any of the ports could be assigned for specific purpose. Like here we have a white port assigned for total parenteral nutrition. We have the red port for blood transfusion, and we have a blue port for intravenous fluid. So this port could be assigned or located for various purposes, depending on what the patient is currently receiving and the purpose of placing the central line. So there are several types of central venous catheters. We have the implanted port, also called the Portacat. We have the tonal catheters, the non-tonal catheters, and like I said earlier, we have the peripherally inserted catheters. For patient selection and indication, most of the time, the indication for central venous catheterization could range from a patient that requires optimal fluid management and where peripheral access seems to be difficult. And this patient could include, but not limited to, patients with severe sepsis or patients that are in septic shock, patients with low urine output, intraoperatively in the theaters where patient access and peripheral access is difficult to cite, patients in other forms of shock, which could be hypovolemic shock. Patients also receiving concentrated vasoactive agents such as noradrenaline. This could be an indication. We have medical reasons such as medical interventions like thrombolysis, multiple drug administration, concentrated electrolyte administration when we want to correct certain electrolyte imbalances. Patients on chemotherapy that are on certain agents that may be toxic or may lead to thrombophlebitis. We would want to place a patient on central venous catheters for those agents. Patients that are also on irritating antibiotics such as the amiodarone and phenytoin and also levofloxacin. Patients that would be on prolonged antibiotic therapy. Patients that may require cardiopulmonary resuscitation, or patients that may require large ball venous access for rapid administration of fluids, depending on the medical condition of the patient. We also have specialized indications, and this include specialized treatment that require high flow rate, such as patient undergoing renal replacement therapy, that's hemodialysis, patient that would want to have plasmapheresis, or patient that may require exchange blood transfusion or extracorporeal membrane oxygenation, which we will need to replace the blood through a machine and then return back the blood after removing the toxin. So such patient would require central venous catheterization to enable the process to move easily without issues. So contraindications for catheterization may include local site infections and burns, patients that may have quite large percentage surface burns that may involve this site that we may need to use, anatomic abnormalities, coagulopathy or thrombocytopenia. Usually coagulopathy becomes a problem if the platelet count is less than 20,000 or the international normalizing ratio is greater than 3. We may need to optimize the patient before the procedure takes place in order to reduce the risk of bleeding. Obtaining consent from patient or surrogate. So the procedure has to be plainly communicated with the patient or the surrogate taking care of the patient. The procedure has to be explained in detail, and this detail includes the benefits, the risks, and the alternative of the procedure in a language they can understand. And the physician is meant to respond to all queries and concerns that may arise from this discussion. And the consent is to be documented and signed by the patient or the surrogate. Prior to this, we would need to secure a peripheral venous access before attempting. Usually, this is necessary in case either the catheterization is abortive, the procedure is abortive, or we may need to resuscitate the patient, depending on the hemodynamic state of the patient. We may need to resuscitate the patient during the procedure so that we can have an access to give whatever drugs might seem necessary at that point in time. Choice of appropriate size. So in choosing the appropriate size, there are certain things we have to consider. One is the coagulopathy. If this patient has any problem with ability for its blood, for either blood to clot, that is why we need to correct any coagulopathy, or we need to have INR results available so that we know the risks of bleeding that may be associated. So in terms of patient with risks of coagulopathy, the femoral route or site is preferred. And the second side of preference would be the internal jugular vein, and the last side would be the subclavian. To decrease the risk of infection that may arise from this procedure, the subclavian is the #1 choice for patients who are at risk of infections. Then in choosing between the right or the left internal jugular vein, the right is preferred over the left due to the fact that it has a larger diameter than the left, and it has a direct path to the superior vena cava. And also there is reduction in terms of injuring the adjacent vessels. In terms of the left side, we would have the thoracic duct, which if we inadvertently puncture it, it could lead to the lymph and fluid seeping into the chest and giving us a chylothorax. So choosing the right internal jugular vein is superior whenever possible in order to reduce the risk of injury to the adjacent structures. So a choice of appropriate catheters. So like I said, we have catheters with single lumen, two lumen, double lumen, multi-lumen. So the fact that we have to keep in mind is that the more the number of lumen, the lesser the diameter of the lumen. So in terms of resuscitating a patient with trauma, which we need rapid fluid infusion, it's appropriate that we choose a catheter with a lesser number of lumen, maybe a single or double lumen catheter. And also in order to reduce the risk of infection, which is directly related to the number of lumens, because the more lumen you have, the more things you would, agents you would need to give, and the more contact patient has with people. And so reducing the number of lumen also helps to reduce or decrease the risk of infection. But aside from that, we also have catheters that are antimicrobial impregnated, such as chlorhexidine, silver sulfadiazine impregnated catheters. And this is meant to reduce the risk of infection. Tonal catheters are known to be ineffective in decreasing infections. We have a central line bundle. This is regarded as evidence-based practices in order to reduce the risks of infection and in order to maintain the central venous catheters properly. So the aim is to reduce any complication that could arise from infections that are related to the central line placement, also known as central line bloodstream infections, CLABSI. So one of the bundles include about 4 things. We have anagen, which entails that the physician has to wash his or her hands with soap and water, or an alternative could be rubbing your hand with an alcohol-based antiseptic. Then the second component of this bundle is barrier precaution, which includes the use of cap and mask and sterile gloves and gown in order to protect the site from other parts of the body, in order to protect the site from the physician's normal ways to reduce the risk of transmission of infection. Then we also have the practice of skin antisepsis. That's rubbing the incision site with 2% chlorhexidine and 70% alcohol solution for about 30 seconds before the line is injected. And also in the choice of cannulation site, it is preferably to avoid femoral vein cannulation due to their increased risk of thrombosis, considering the fact that femoral veins are major venous drainage channel in the lower limbs, and also to reduce septicemia that could be associated with this choice. So we'll be looking at relevant anatomies for our choices of vessels. So our first anatomy here is for internal jugular vein. So internal jugular vein is the most popular site at the base of the neck for placement of central venous catheters. And it's located under the sternocleidomastoid muscle on either side of the neck, which means that we have right and left internal jugular vein. And it's in terms of the adjacent structure, it's anterior and lateral to the carotid artery. So at the base of the neck, this vein, at the base of the neck, the internal jugular vein and the subclavian vein unite to form the innominate vein, which now converges to form the superior vena cava. Then the second vessel we are considering is the subclavian vein. The subclavian vein crosses under the clavicle, just medial to the mid-clavicular point. And it lies underneath the clavicle at the intersection of the lateral edge of the sternocleidomastoid muscle in the clavicle, and is separated from the subclavian artery by the anterior scalene muscle, which lies deep in the vein itself. The femoral vein is another site of cannulation, and it's located in the femoral triangle, and is about 1 to 1.5 centimeter medial to the femoral artery at the inguinal ligament. And this vein may be difficult to palpate in patients that on the big side, patients that are obese. So some anatomy of the relevant vessels. So it is recommended by NICE that ultrasound should be used in order to reduce the rate of complications that could arise for central venous catheterization. And due to this fact, it is not important that physicians acquaint themselves with the use of ultrasound in order to reduce the complication and the risks associated with this procedure. So the ultrasound that is relevant for this procedure is regarded as the vascular ultrasound, which is the real-time imaging of blood vessels using an high-frequency sound waves. So it's the gold standard for guiding safe central line and even arterial cannulations to minimize complications. And it helps to distinguish between veins and arteries, which veins are seen as vessels that appear anechoic, that's dark, in comparison to the adjacent structures with thinner walls and easy compressibility, while arteries would be pulsatile and would have thicker walls. So real-time visualization allows the anesthetist to watch as the needle tip enters the targeted vessel. The equipment and the techniques needed for this vascular ultrasound include a transducer, a high-frequency linear array probe with 6 to 13 megahertz is typically used for superficial vascular imaging. And this is so because the higher the frequency of the probe, the less penetrating ability, but the better resolution it will give. And most of these vessels are not quite so deep. So that is why we require a high frequency probe. Also require a machine that has a color Doppler and this ability in order to map the direction and the velocity of flow, in order to identify which vessels would be a vein or an artery, because usually the veins are coated with the blue colors, while the arteries are coated with red colors. But this actually also depends on the angulation and the placement of the probe. And that is why it is important that we have to acquire a specialized training for this. So the needle approaches for this procedure include in-plane technique, also known as the longitudinal axis. So the longitudinal approach requires that you place the probe across the vessel and you're able to see the entire length of the vessel, which would appear in dark or anechoic, and then you're able to monitor the needle and to see if you are within the vessel. An out-of-plane approach is the short axis approach, which enables you to identify not just the vein of interest, but also the adjacent structures, and also differentiate which one is an artery and which one is a vein, so that you don't puncture an artery inadvertently. In order to do this, an anesthetist requires some form of training in ultrasound, which would reduce the risk or would reduce the operator dependence in terms of what we see. So this is a B-mode image of ultrasound image of internal jugular vein, showing the vein itself with an adjacent structure, which is the carotid artery, which looks smaller than the internal jugular vein. And we can also see the thyroid gland adjacent to that and the muscle plane. So typically the vein appears larger and darker in terms of the content, and also have thinner walls. So this is just a pictorial representation of what a vein or internal jugular vein would look like if we are using the ultrasound approach. Then this is also the zone anatomy for the subclavian vein. You can see the subclavian vein also appears larger, but the problem with the subclavian approach, because of the clavicle, which tends to impede the transmission of the ultrasound, because of the bone resists the transmission of the sound from the probe into the tissues. The resolution for this is always poor because of the impedance of the clavicle, which resists the transmission of the ultrasounds across the relevant tissues. This is also an anatomy of the femoral vein. You can see the femoral vein with an adjacent femoral artery, and we've seen below that is the Doppler image, which shows the femoral vein being coated with a blue or a purple color, and the artery coated with a red color. So when the Doppler effect is applied through certain principles in the machine, this is what we eventually see. And this also helps to clearly distinguish which of the vessel is an artery and which of it is a vein. So equipment needed for cannulation, we need standard monitor for us to begin the cannulation. Standard monitors that would include an ECG, a pulse oximetry, blood pressure monitoring instrument. We need materials for sterile preparation, cap and mask, sterile gowns and drapes. Also need a cleaning agent, 2% chlorhexidine with alcohol. We need a needle and a syringe, a sterile saline flush. And also sometimes a perine flush can be used in order to reduce the risk of clotting, but it depends on availability. So we need a sterile cannulation set with a central venous catheters, a guide wire, a locator needle with syringe, a needle holder with a suture material. Most of the time is the nylon, a sterile dressing. For step-by-step procedure, the physician has to wear a cap, mask himself and then gown, wash hands with alcohol-based and rub for about 3 to 5 minutes, and then clean the skin of the patient with about 2% chlorhexidine in alcohol preparation, and then give a frictional scrub in a circular motion to the site of interest to cover about 10 centimeter area away from the insertion site, and then place a sterile drape over the insertion site. So in whatever approach we are going to use, whether it's the landmark method or the ultrasound guided method, the technique appropriate for this cannulation is regarded as the Seldinger technique. And the Seldinger technique, I'm going to describe the steps as follows. So the patient is placed in a trabecular position with head. Trabecular position, usually we know that the head is below the horizontal line, and with the head turned towards the opposite side of chest. So if you are using the right internal jugular vein, you turn the patient's head to the opposite side, and also you place shoulder rolls along the spine of the patient in order to make the vein prominent and increase the diameter of the vein. Then for your infiltration, 1 to 2% lidocaine is used for local infiltration before the cannulation in order to numb the site and to reduce the pain. Then the desired vessel is punctured with a sharp hollow needle called a trocar. Then following that, blood will be withdrawn into the vessel. That's an evidence that you are in the vessel when blood flows freely into the syringe through the trocar. That's the needle that you use to puncture. Then a rounded tip or jet-shaped guide wire is then advanced through the lumen of the trocar with the vessel. The trocar is then withdrawn, leaving the physician only with the guide wire within the vessel. Then there is dilatation of the tract using a dilator, which is a component of the kit, usually in a rotating or a circular motion. Then the catheter is then passed over the guide wire into the vessel that has been punctured. Then the guide wire is then withdrawn, leaving the catheter in situ. And the goal is never to let loose of your guide wire, because if you let go of your guide wire, you would have lost the vessel, because that is what keeps you in the right channel. So the goal is always to grab your guide wire as much as possible. So for positioning and technique, so like I said, usually most of this cannulation is done with the patient in the trabecular position. Like I said, you have to tilt the body so that the head is below the horizontal line in order to distend usually the internal jugular vein, and in order to facilitate cannulation. Then slightly rotate the head to the opposite direction in order to straighten the course of the vessel. Then in using an ultrasound approach, this ultrasound could also help us to identify the vessel easily, like I said before, but this depends on if the physician has been trained to use an ultrasound or not. So identifying the landmark in terms of the landmark approach. So the internal jugular vein is identified in the triangular area at the base of the neck, created by the two heads of the sternocleidomastoid muscle. And they run concurrently with the carotid artery through that triangle. So the first thing is to locate the carotid artery and to locate the carotid pulse and retract it towards the midline and away from the internal jugular vein, because the internal jugular vein is anterior and lateral to the carotid pulse. Then with your bevel of the needle facing up, you then insert the needle at the triangle and advance the needle towards the ipsilateral nipple at about 45 degrees angle. And it is advised that if the vein is not pierced or entered by depth of 5 centimeters, the needle should be withdrawn and re-advance again in a more lateral direction. Perhaps you would have slipped off the course. So you have to withdraw it and redirect it again. So complications that could arise from here include accidental puncturing of the carotid artery, and there could also be mechanical complications like puncturing adjacent vessels such as pieces of the lungs, which could lead to pneumothorax. There could also be catheter-related septicemia with internal jugular and venous catheters. For subclavian vein usually was a favorable site before the emergence of ultrasound, but due to the limitation of ultrasound use because of the clavicle that impedes the transmission of the sound waves. So the ultrasound approach is not likely to really give a superior picture because of the limitation of the clavicle that impedes the sound waves. So like I said, the subclavian vein is a continuation of the axillary vein as it passes over the first rib. It runs under the clavicle and the first rib at some point about only 5 millimeters above the apices of the pleura of the lungs. So it has a higher risk. This side has a higher risk of pneumothorax. The vein is about 3 to 4 centimeters in length and has a diameter of about 7 to 12 millimeters in a supine position patient. So for positioning an approach and when choosing the subclavian vein, so the head of the patient has to be tilted downward and to about 15 degrees downward. That's to the lumbar position, about 15 degrees down, to increase the diameter of the vessel. Using the infraclavicular approach, you identify the clavicular head of the sternocleidomastoid muscle. The sternocleidomastoid has two heads, the clavicular head and the sternal head. So you identify the clavicular head, and this is where the subclavian vein is inserted, and this is where you have to make your insertion. So you mark the region of the clavicle that overlies the vein, and then you enter the vein from below the clavicle in this region. And it is advised that at the lateral edge of the marked area, that the probe should be inserted at about, the probe of the needle should be inserted at about 12 o'clock position, just below the clavicle. And then the needle should be advanced along the underside of the clavicle in the direction of the suprasternal notch. And the needle should be able to pierce the subclavian vein within a few centimeters, because it does not really have a long course at this region. When the vein is punctured, the bevel of the needle should be turned to about 3 o'clock to help direct the guide wire into the superior vena cava. It is also noted that in obese patients, this vein may lie deeper than it should be, and as such, the needle may need to be directed more deeply into under the clavicle than necessary in obese patients because of the subcutaneous tissue and the fat. So complications that could arise from here include inadvertent puncturing of the subclavian artery, pneumothorax if the epiphysis of the lungs is being injured, brachial plexus injury, catheter malposition, and risks of stenosis. Femoral vein is considered the least desirable side because of the risk of thrombosis, because it's a major venous drainage side, the risk of thrombosis. So anatomically, femoral vein is a continuation of the long saphenous vein into the groin, and is the main conduit for drainage of venous drainage of the leg. So it's a major site for at risk of a thrombosis. So like I said before, it's located in the femoral triangle. So the superior border of this femoral triangle is by inguinal ligament running from the superior the superior border of the femoral triangle is formed by the inguinal ligament, and this runs from the anterior superior iliac spine to the pubic tubercle or the pubic symphysis. And beneath this is where these structures are located. So the femoral vein locates itself medially to the femoral artery, about 1 to 1.5 centimeters medial to the femoral artery. You would have to palpate for the pulsation of the artery in order to distinguish between the vein and the artery. So for positioning using this site, the upper body of the patient has to be elevated above the horizontal plane. Also, this is regarded as reverse radiolumbar in order to increase the cross-sectional diameter of the vein. But using the ultrasound approach, this and the pulsation of the femoral artery could easily distinguish this from the vein itself. So for the landmark approach, the artery is located in the inguinal crease, and then medial to that is the femoral vein. Then the probe of the needle is inserted at about 12 o'clock position, and about 1 to 2 centimeter medial to the pulsation, which is the site for the artery. The vein should be entered or pierced at a depth of 2 to 4 centimeters away from the skin. Like I said earlier, the principal concerns for this site or the choice of this site is mainly thrombosis and septicemia. Immediate concerns that could arise from this procedure include venous air embolism. The impact of air entry into the venous circulation is determined mainly by the volume of air and the rate of entry. So when air reaches about 200-300 mils over a few seconds, when there's a rush of air into the veins, it can be catastrophic. And so it could lead to right heart failure because there could be some blockage, or there could be some air left in the right ventricular system that could lead to right heart failure, form of embolism, and then a failure. Clinical symptoms and signs that could help us identify if this patient has any air embolism would be sudden onset of dyspnea and distressing cough. And this could also be heard using our stethoscope. And during auscultation, this sound is regarded as the Mio-wheel sound. The Mio-wheel sound is produced when there is a mixture of air and blood in the right ventricle. It gives a splashing auscultatory sound. So transesophageal echocardiography is regarded or considered the most sensitive method of detecting air in the right heart. But this venous air embolism could be prevented. The risk could also be reduced by proper positioning, which include tilting the patient's head down in the tridilumbar position when performing this procedure. Management of air embolism includes attaching a syringe to the catheter and attempting to aspirate air from the bloodstream, placing the patient on 100% oxygen in order to promote the movement of nitrogen out of the air bubbles into the bloodstream, placing the patient in a lateral decurvatus positioning to move the air pockets from blocking the outflow of the right ventricle. Pneumothorax is also one of the immediate concerns that could arise from this procedure, and usually it's most associated with subclavian venous and cannulation because of the closeness of the vessel to the apices of the lungs. And this is where a chest radiograph has a role to play, though the sensitivity is poor because most of these patients are located in a supine and are placed in a supine position. So the pleural air most of the times would be missed because the air is in front of the lungs, and the sensitivity of the portable chest X-ray is reduced when patients are in supine position because you will not be able to really visualize the basis of the lungs and all of that. The pleural air does not collect at the apex of the lungs in a supine position, but rather it's close to the base of the lungs. So most of the portable chest radiograph are considered AP radiograph instead of the standard and posterior anterior radiograph. So it may be difficult to truly assess the basis of the lungs. So catheter position. Catheters inserted via the internal jugular vein and the subclavian veins should be in the superior vena cava with the tip at about 1 to 2 centimeters above the right atrium. And catheters should follow a straight course down the mediastinum, and the tip of the catheter should be above the carena. Carena is just above the junction between the superior vena cava and the right atrium. So this is another reason to have a chest radiograph done after placement, because you want to be sure that your catheter is correctly placed. There is no malpositioning. So this is one of the concerns that could arise immediately after central venous catheterization. So this is a chest radiograph showing an ideal position for central venous catheters. We've seen that there's a safe window line that is indicated with an arrow that a catheter should be found. Then that is from the carena, the bifurcation of the right and the left main bronchi to a certain centimeter and just below that. So this area is regarded as a safe window where the tip of the catheter should be. Anything that is beyond this is considered that the catheter has been malpositioned or misplaced and may need to be readjusted. So mechanical complications that could arise from this procedure and the interventions that could be done in order to limit or to reduce the risk. So if there is an arterial puncture or a venous puncture that results in significant bleeding, it is advised that the vessel pressure should be applied to the vessel for about 15 minutes In terms of hematoma and hemothorax, it advised that patient coagulopathy should be corrected, and then a patient's coagulopathy should be corrected and other things that are necessary in order to reduce the formation of the hematoma. Cardiac tamponade that could also arise from this procedure, or perforation that could arise from this procedure, would need a surgical intervention from the cardiothoracic surgeon. So it's an high risk procedure that everybody needs to be careful and look out for problems that could arise. There could also be risks of thoracic duct injury, especially, like I said earlier, if the cannulation is done on the left side where the structure is located. In terms of pneumothorax, it is advised that intercostal tube drainage be done to reduce tension pneumothorax. And also needle thoracentesis can also be done to reduce the tension and to relieve the patient. Tracheal injury can necessitate intubation. Patient could also have arrhythmia if the catheter reaches the right atrium. It could also lead to arrhythmias because of that the catheter has gone deeper than necessary. Like I said, air embolism is also a problem with this procedure, and we had already discussed how to manage that. We could also have complications arising from bacteria or infection-related complications that could arise from this procedure. We have catheter-related bloodstream infections, and we also have endocarditis as well. So central line-associated bloodstream infection may be defined as a recovery of pathogen from blood culture in a patient who had central line at the time of infection or within 48 hours, or at the infection within at central line within 48 hours before the development of the infection. So possible pathogens that could be associated with this infection, that we have both gram-positive pathogens and gram-negative. For gram-positive, we have Staphylococcus aureus, Enterococci, and bacteria, and for gram-negatives, we have Klebsiella and Enterobacter. Prevention of infections and complications related to infections. It is advised that we use central venous catheters with a minimum number of ports. We use sterile gauze to cover the catheter side and replace the dressing every 2 days or as necessary for gauze dressing, and then every 7 days for transparent dressing. That this is not casted on stone. If the dressing is sold, it is advised that we inspect it daily and change the dressing as necessary. And inspecting the site daily for signs of infection is also a means of preventing complications from infection. Using povidone iodine antiseptic ointment or bacitracin or polymyxin B ointment at the site of the catheter is also important, usually for patients using these catheters for hemodialysis, and cleaning it at the end of each dialysis session is paramount to reduce the rate of bacteria-related infections. When to remove the line? So it is advised that central venous catheters be removed as soon as it is not needed by the patient. Again, when there is an induration, redness, or post-discharge from the site of cannulation, when there is a suspected or confirmed catheter-related infection, and catheter occlusion and thrombosis is also a reason that catheter should be removed. When there is an erosion of the vessel that was used for catheterization, it's also advised that the line be removed so that the vessel could heal. Estimated time for removal of several of catheters depending on the site. For femoral lines, it is advised that it should be removed by the 7th day, and internal jugular lines could be removed within a period of 2 weeks. Subclavian lines should be removed within a period of 3 weeks. But all these rules are not fixed, so it depends on the need and other, like I said, other reasons, like I listed earlier. So it is not, these are not fixed rules or principles, so it is patient situation or case. So in conclusion, central venous cannulation is an indispensable procedure in modern day medicine for a long-term access and also for hemodynamic monitoring and specialized therapies and treatment. Adherence to sterile barrier precautions and ultrasound guidance is mandatory to reduce complications. Proper care and prompt removal of unnecessary catheters are the best ways to prevent infections. These are my references. Thank you for your time and your attention.
Thank you so much, Dr. Rufus, for the very, very robust presentation. So over the last 50-ish minutes, she's presented central venous cannulation, touching on the indications, patient selection, what it is, the techniques, the sonoanatomy and the landmark approaches as required, the complications and how to manage them, and ways to manage them. So I would like to entertain questions at this point. I've checked the chat box and there are no particular questions. Okay. Okay, I found some now. The first one says, how long should the CVC be left in situ prior to change? And then the second one says, can a central line be cited for use in the ward? Please, could you answer those two questions?
Okay, the second question I didn't get, please.
If it can be cited in the ward, because I think you mentioned it's
Okay.
being done mostly for ICU patients and then
Okay.
intraoperatively. So she was asking if it can be done on the ward.
Okay. Okay, thank you for your questions and it's well received. Thank you. So for the first question, the question is asking me about the duration that a central line should be left in place. Like I said, for the femoral lines, it is advised that it is used for about a week, then the internal jugular veins for about 2 weeks, then the subclavian for about 3 weeks. But however, these principles are not fixed. You have to inspect the site of the incision or the cannulation and also observe the vessel. If there are erosions or if there are induration, if there are pores coming out, it has to be changed. So it's per case, per the patient situations. But averagely, these are estimated time that it should be kept in place. But if there are concerns arising from the cannulation, then it could be changed at any point in time. So it is not a fixed principle. Then for the second question, if central lines could be placed in the ward or patient could be catheterized in the ward, it is not advisable to put a central line in the ward. One, because you need appropriate monitor to monitor the patient, and most of the times depending on the environment, we may not have those monitors, the ECG and the pulse oximetry, and even oxygen in case patient desaturates. Most of these things are not routinely available in certain wards, but most of the time. So I think it depends on the center. And if you have these things available in the ward, the ward is optimized to deal with such emergencies. If you run into issues that you need critical care support, if that ward is equipped to enable you to handle that situation, I think you can. But in our environment here, most of our wards are not equipped to that level of operation. So it's advisable you do it in a place that you can critically monitor the patient if you run into trouble. So that is why it is best to have it done in the intensive care unit or maybe high dependence care unit, depending. Thank you.
All right, thank you, Dr. Rufus. There are more questions in the chat box.
Okay.
All right. So one of the questions is saying that who should actually cite the central line, the anesthetist or CTSU? Another saying that you mentioned coagulopathy as a contraindication to central venous cannulation. So are you saying that DIC, disseminated intravascular coagulopathy, is a contraindication for the procedure? They're also asking, in the absence, would you take those two, or should I read all the questions at once?
Yeah, let me take the two.
All right.
So for who should place the central line? Well, I think it's not fixed. It's not a fixed principle. A trained anesthetist should be able to place a central line. But however, in some centers, depending on the patient's background health challenge, it's also that times you could invite the cardiothoracic unit, the cardiothoracic surgeon, to also place the central line. So I think it depends on access to whoever is in your center. Do you have an anesthetist in your center that could place it easily if the patient needs it? Fine. If you don't have an anesthetist, is there a cardiothoracic surgeon? Fine. So I don't think it's really a fixed principle. But if the patient is in ICU, most of the times, the patient, the central line will be placed by the anesthetist most of the time. So it just depends on access to a trained personnel in each center. Then for the second question that talked about coagulopathy, yes, coagulopathy, it's a relative contraindication, but this still depends on the platelet count. Like I said, platelet count less than 20,000. It's considered an high risk. The patient is considered an high risk patient in terms of the bleeding potential. So the patient is more prone to bleed. And it's also advisable that patient be optimized by giving either a fresh frozen plasma, or maybe also giving a particular factor if a patient is factor deficient, in order to optimize that patient to reduce the risk of bleeding. So, but everything we read, is this procedure really necessary to keep the patient alive? Is it something that we can make do with other means of access, venous access, while optimizing this patient? Because you don't also want to run into a situation that the patient bleeds and then the catheterization was not possible, and then you have a case that a patient is not also hemodynamically stable. So it's going to be where the risks and the benefit at that point in time. But if we have time, it is advisable to correct any coagulopathy before it is being attempted, for the safety of the patient and also the physician trying to do the procedure.
Okay. Sorry, good evening.
All right, thank you. The other questions.
Before you continue, hello.
Moderator, please, one of our chiefs, Dr. Adesina, has a hand up. So please, let's let
our big madam speak. Chief Ma, so good to have you
here. Please, you have the floor, ma.
Thank you very much, Dr. Afam. I just wanted to make a comment. Thank you very much to the speaker. That was a very good presentation. So I wanted to make a comment concerning the who should cite it. I want us to go away from this lecture knowing that skills can be learned by anybody. So in our own environment in Nigeria, we have some shortcomings because some of us don't have access to maybe the POCUS or any ultrasound machine to do it. Secondly, some institutions don't even have the central line. When we started residency, it was a thing basically done mostly by anesthesiologists. But then eventually the cardiothoracic surgeons, because it's a skill that can be learned by anybody, caught on to it and also do it regularly. I also agree with her. Some of them might be, for example, we want to place a subclavian in a patient that has pericardial effusion or cardiac abnormalities, then you might want those people around. Having said that, it is a skill that can be learned by everybody. You know what the indications and contraindications and possible complications are, so you make sure you take your precautions. You know what your limitations are. For example, you want to do it in a particular patient, maybe a pediatric patient, and you're not really skilled, you've not done it before under supervision, then you might need a more experienced person, not necessarily a cardiothoracic surgeon, to be with you so that your complications are less. Hold your hand while you get better with that skill. The second thing is, like we have all said, I wish you could go more into pictures for ultrasound, ultrasound pictures of what you see when you are actually doing this procedure. When I was in Nigeria, it wasn't easy. We really didn't have access to ultrasounds. But where I practice now, ultrasounds are everywhere. So you have them. My residents, I don't even think they know how to do landmarks so much because it's just there and it's so much easier, it's faster. So we're hoping as we go on that these things will be available because nobody does so much of blind technique anymore. However, like I always say, it's good. You don't know where you're going to practice. Maybe you're going to be practicing in a local place to always have your skills. And the landmark also still comes up in even using your ultrasound. Because if you don't know where you're doing your landmark, where you're going to put your ultrasound, you might also still have difficulty. So maybe one day we will do another presentation on ultrasound technique to do this. It's very important. Then concerning the length, somebody asked about the length. Maybe she's going to take that question, but I could just quickly put in that not just knowing the length, but knowing if you've gone in too far. And this is where you put in your ECG, because if you are going too far and you go beyond the SVC and then you are going into the further than you should, you will see arrhythmias on the ECG. So this is a good way to also guide yourself. But rule of thumb, if you are using the right internal jugular, 15 to 16 cm, the adult, left internal jugular 16 to 20, and subclavian 14 to 17 cm. So finally, I want to say, can it be done in the ward? Very much so. Like I said, and you also mentioned, it also depends on where you practice. So if you have your full 5-parameter monitor in the ward, where you can do your ECG and other things, you have access to sterile equipment, you have access to adequate assistance, you have your tiltable, trolley, or bed. Why not? We've done it in the wards many times. So it's not a theater procedure. In the emergency departments, they do it regularly. Emergency residents do it. Internal medicine, who are interested and learn the technique, they do it. So as long as everybody knows what to do and what to abstain from. And this also goes for any other skill. For example, do we do pleural taps in ICU as anesthesiologists? Can you do a tracheostomy? Why not? If you are skilled and it's life-saving, please go ahead and do it. Learn the skill and do it. Thank you.
Thank you so much, Chief.
Thank you very much, Ma. Thank you so much for your contributions and inputs. It's been very, very helpful. I think you've answered most of the pending questions. The only other question now will be how far the guide wire should go when placing the central line. That is, when do you know to stop advancing the guide wire? I think that's the only question left unanswered. So, Dr. Rufus.
Okay, thank you for the question.
Can we hear me?
Yes, you're audible.
Also,
Dr.
okay.
Rufus. Dr.
minutes.
Irene, please, can you mute your mic?
All right. Am I audible, please?
Yes, you're audible. Yes, we can hear you.
No, thank you. And is all very strong comments, and I'm certain that everyone while we're waiting to see if the people as usual. So
Let's go. I miss you.
Sorry, Chief, you're breaking up. And if we could mute
can you
Dr. Irene so that we can hear clearly. There's background noise from our end.
hear? Okay. The video recording of rewatch and increase our to the educational committee of the NSA for giving a presenter who has done a very we are very grateful to our senior colleagues.
Okay, Dr. Afam, can I just make a comment before you round off? Hello, Dr. Afam.
Or was it before?
Hello, Dr. Afam.
Okay.
Dr. Afam.
Am I audible? Chief,
Yes, you
please
are.
go ahead. This network is breaking.
Okay, so I just wanted to answer the question on the length of the guide wire that we allow in. Now, you have to remember that your guide wire is a guide. So in other words, you don't lose, one of the complications that can arise is to lose your guide wire. So you don't lose contact or sight of the guide wire. So you introduce it to the length to enable you then railroad your catheter. So in other words, you put enough there such that when you introduce your catheter, you can easily put your hand at the contact that the guide wire has at the skin. I hope you understand what I'm saying. So you keep your hand on it with the guide wire on the skin, then gradually introduce with the help of somebody else your catheter. So you begin to pull it out gradually without losing contact with it until it then usually it comes out through the white portal, the portal of if it's a 3 lumen. So the moment it then comes out and you can hold on to it at the tip of that white, then you can further hold it firmly so you don't lose it and then thread your catheter all through into your through the guide wire. So you can't really say how much per se, but it's safe to say enough to enable you still have contact with it and also introduce it your catheter. So I think that's a good way to look at it. Thank you.
Thank you very much, Ma. Dr. John Afam, are you back now?
much, Chief, for that comment. Yes, I am back, Dr. Ishola. Thank notes. We really appreciate you, ma. We will be doing our closing formalities now. Our Chief, Dr. Adesina Aderonke, who has given us some very research, read, learn, and Chief said, it's a procedure that you can learn, that everyone can learn. So this is the theory. So thank you everyone for joining. For the rest, the slides and we'll share other discussions, all the unanswered 2 weeks, we'll be having our next presentation. So please look out. Again, we are very grateful to the NS participation as we've had today, and more growth in our respective. So good evening, everyone. I remain the training. People are just logging out. At least some of you are safe. Bye-bye.
Bye-bye.
Thank you, Chief. It's been a wonderful. Well done. Dr. Rufus, well done too. Thank you for the wonderful hosting and presentation.
Thank you for presentation.
Thank you.
Please, can we get the slide on the group page? Thank you.
Yes, I was about to ask, could you help us send the slide so that we can make good references next time?
Thank you, Dr. Afam. Bye.